Welcome to this educational video on schizophrenia and related psychotic disorders, designed for learners with a basic science background. This presentation is modeled after a clinical psychiatry and neurology grand round session. In this video, we will explore 6 core learning objectives: defining psychosis, examining neurobiological theories, recognizing symptom domains, differentiating conditions, outlining treatment approaches, and identifying pathways into care. We begin with the foundations, focusing on understanding what psychosis is and how schizophrenia fits into the broader diagnostic landscape. Psychosis is a state where the mind loses touch with reality, characterized by hallucinations, delusions, and disorganized thinking. It is a syndrome, not a single diagnosis, with various psychiatric, medical, and substance-related causes. Schizophrenia is a primary cause of chronic psychosis. The DSM-5-TR categorizes the schizophrenia spectrum. Diagnoses include schizophrenia itself, requiring at least 6 months of illness, as well as brief psychotic disorder, schizophreniform disorder, schizoaffective disorder, delusional disorder, and schizotypal personality disorder. Epidemiologically, schizophrenia has a lifetime prevalence of roughly 0.3 to 0.7%. It typically presents in the late teens to 20s for men and mid-20s to 30s for women. It is a major cause of disability and is associated with reduced life expectancy. Next, we examine the causes and neurobiology of the disorder to understand why it develops. Schizophrenia is understood through the biopsychosocial model, recognizing that there is no single cause. It involves a convergence of biological, psychological, and social factors, often explained by the stress diathesis model, where genetic vulnerability meets environmental triggers. Genetics play a significant role, with heritability estimated at 60 to 80%. Studies on twins and families show that risk increases with genetic closeness to an affected relative. The condition is polygenic, meaning it is not caused by a single gene. Specific risk variants have been identified through genome-wide association studies, revealing over 100 common risk loci. Rare variants, such as the 22q11.2 deletion, also confer significant risk. Genetic factors often interact with environmental stressors, such as early adversity. The neurodevelopmental hypothesis suggests that early prenatal or perinatal disruptions in brain development create a silent lesion. This vulnerability may remain dormant until triggered by adolescent processes, such as excessive synaptic pruning, leading to the onset of symptoms. The dopamine hypothesis remains central to our understanding. It posits that mesolimbic hyperactivity is linked to positive symptoms, while mesocortical hypoactivity relates to negative and cognitive symptoms. Antipsychotic medications primarily act by blocking D2 dopamine receptors. The NMDA hypothesis focuses on glutamate, suggesting that NMDA receptor hypofunction drives cortical disconnectivity. This model may better explain negative and cognitive symptoms. It also serves as a foundation for developing new, non-dopaminergic therapeutic agents. Other neurotransmitter systems are also implicated, including serotonin, GABA, and acetylcholine. Additionally, neuroinflammation, particularly microglial activation, is a suspected mechanism. Ultimately, no single neurotransmitter fully explains the complexity of schizophrenia. Structural brain changes are frequently observed, such as lateral ventricular enlargement and reduced volume in the prefrontal cortex and hippocampus. While these findings are consistent in studies, they are modest and not diagnostic for any individual patient. We now turn our attention to environmental risk factors. These included developmental and social elements, such as urban upbringing, experiences of migration or adversity, prenatal infections, and childhood trauma. Perinatal factors like obstetric complications, advanced paternal age, and the timing of birth also contribute to the cumulative risk profile. Substance use, particularly adolescent cannabis use, is strongly associated with an increased risk of psychosis. This risk is dose-dependent and heightened by higher potency THC. Other stimulants, like amphetamines, can also trigger psychotic episodes, potentially unmasking latent vulnerability in those genetically predisposed. Next, we will focus on recognizing the symptoms of schizophrenia, moving from formal diagnostic criteria to what you might observe in clinical practice. The DSM-5-TR defines criterion A for schizophrenia by 5 core symptoms: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. To meet the criteria, an individual must exhibit at least 2 of these, with at least 1 being from the first 3 categories. Beyond these, criteria B through F involve functional decline, a minimum 6-month duration of signs, the exclusion of other mood or schizoaffective disorders, the exclusion of substance or medical conditions, and considerations for individuals with a history of autism or childhood communication disorders. Hallucinations are perceptions experienced as real without an external stimulus. Auditory hallucinations are the most common, frequently appearing as derogatory or commanding voices. Other types, such as visual or tactile, warrant thorough medical investigation. Unlike illusions, they lack an external trigger, and patients often show impaired insight. Delusions are fixed false beliefs held with conviction, despite contradictory evidence. Common types include persecutory, referential, grandiose, and somatic delusions. They can be classified as either bizarre, which are physically impossible, or non-bizarre, which are merely implausible, yet still inconsistent with reality. Disorganized thinking and speech are assessed by the form rather than the content of expression. This includes loose associations or derailment, tangentiality where answers miss the point, severe incoherence known as word salad, and the use of neologisms, which are invented words with idiosyncratic meanings. Disorganized and abnormal motor behavior can manifest as anything from childlike silliness to severe agitation. It often involves difficulties with goal-directed self-care and stereotyped, repetitive movements. These behaviors can significantly disrupt daily functioning and may sometimes overlap with catatonic feature. Catatonia is a psychomotor syndrome marked by signs like stupor, waxy flexibility, mutism, and negativism. It is not unique to schizophrenia and may be seen in various mood and medical conditions, requiring medical assessment. First-line treatment typically involves benzodiazepines, with electroconvulsive therapy as a strategy for refractory cases. Negative symptoms are often categorized by the 5 A's, affect, such as blunted emotional expression, alogia or reduced speech, avolition, showing a lack of motivation, anhedonia, the inability to experience pleasure, and asociality, which is a reduced interest in social engagement. Cognitive symptoms involve impairments in working memory, attention, and processing speed, alongside executive dysfunction. These issues often precede the onset of psychosis and may persist even during remission. They represent a significant treatment gap, as they are not fully addressed by traditional antipsychotic medications. The course of illness is typically described in 4 phases: premorbid, prodromal, acute or active phase, and the residual phase. The long-term trajectory can vary between a relapsing-remitting pattern and a chronic course over many years. Prognosis varies, with roughly 1 in 5 patients achieving functional recovery. Poor prognostic factors include male sex, insidious onset, and poor early social functioning. Conversely, acute onset and strong social support are favorable. Engaging in treatment as early as possible is a key factor in improving long-term outcomes. In the next section, we will review the related disorders that fall within the schizophrenia spectrum, differentiated by their unique duration and mix of symptoms. Schizophreniform disorder shares the exact criterion A symptoms of schizophrenia. However, its duration is shorter, lasting between 1 and 6 months total, including the prodromal, active, and residual phases. Unlike schizophrenia, a significant functional decline is not required for a diagnosis of schizophreniform disorder. Regarding outcomes, approximately 1/3 of individuals recover completely, while others may progress to a diagnosis of schizophrenia. Brief psychotic disorder is characterized by the sudden onset of at least one positive symptom. The episode lasts from 1 day to less than 1 month, and individuals experience a full return to their previous level of functioning. A common trigger for brief psychotic disorder is acute severe stress, sometimes referred to as, quote, brief reactive psychosis. Additionally, postpartum onset is a recognized specifier for this condition, which generally has an excellent prognosis. Schizoaffective disorder involves an uninterrupted period of illness, during which a major mood episode is present concurrently with criterion A symptoms for schizophrenia. To differentiate it from mood disorders with psychotic features, the diagnostic criteria require at least 2 weeks of delusions or hallucinations in the absence of prominent mood symptoms. In schizoaffective disorder, mood symptoms must be present for the majority of the total illness duration. It is classified into bipolar and depressive types, and the diagnosis is often revised over time as the longitudinal course clarifies. Delusional disorder is defined by the presence of at least one delusion, lasting for at least 1 month, without meeting the full criteria for schizophrenia. Functioning is generally preserved outside of the specific delusional theme. Subtypes of delusional disorder include erotomanic, grandiose, jealous, persecutory, and somatic. Because the behavior is not always overtly bizarre, it can be difficult to detect, and limited insight often presents a significant challenge for treatment engagement. Schizotypal personality disorder is classified as a cluster A personality disorder. It is genetically linked to the schizophrenia spectrum and features eccentric behavior, odd beliefs, magical thinking, and social anxiety. Unlike acute psychotic conditions, schizotypal personality disorder typically manifests as a chronic, trait-level pattern starting by early adulthood. Only a small subset of individuals with this diagnosis will eventually develop a full-blown psychotic disorder. Substance or medication-induced psychotic disorder involves symptoms arising during or shortly after substance exposure or withdrawal. Common causes include stimulants, cannabis, and certain medications like corticosteroids or dopaminergic agents. Symptoms should exceed those expected from simple intoxication or withdrawal, and typically resolve after a period of abstinence. Psychotic disorder, due to another medical condition, occurs when psychosis is a direct physiological consequence of an illness, such as epilepsy, autoimmune encephalitis, or endocrine disease. A new onset of psychosis in older adults should always prompt a thorough medical workup to rule out these underlying factors. Differential diagnosis is critical. For example, major depression with psychotic features involves mood-congruent psychosis without a, quote, psychosis-only window, while bipolar disorder, manic type, involves symptoms confined to manic episodes. The longitudinal course is the most important tool for differentiating these conditions. Comorbidities significantly complicate management. Substance use disorders occur in nearly half of individuals with schizophrenia, impacting treatment adherence and relapse rates. Meanwhile, cardiovascular disease is a leading cause of premature mortality, often exacerbated by lifestyle factors and medication-related side effects. Finally, we address safety. Suicide risk is high, with a lifetime prevalence of 5 to 10%, particularly early in the illness. Consistent, non-judgmental risk assessment and robust safety planning are essential components of comprehensive clinical care for anyone on the schizophrenia spectrum.